Hi everyone, my name is Jennifer Dickey and I'm a researcher at Mathematica. I'd like to welcome you to our session uncovering and addressing disparities in health-related social needs screening and navigation using data to drive change. So today I'm joined by my colleagues Christine Ogbue from Centers for Medicare and Medicaid Innovation Center, Dan Behrens from Allina Health, and Sharif Mohamed from Open Path Resources. And we're all connected through our various roles supporting the implementation of and advancing lessons learned from the Centers for Medicare and Medicaid Innovation Center Accountable Health Communities Model. So we'll start today's presentation with an overview of the AHC model from Christine, which has 28 awardees across the United States. And then we'll narrow down to one awardee, Allina Health, and you'll hear from Dan about how they use data and community engagement to drive change. And then you'll hear from Open Path Resources with their partnership with Allina Health, and Sharif will share more about this partnership. And then hopefully we'll have some time together at the end to share on collective lessons learned for advancing equity. So throughout today's presentation, we'd like to invite you to engage with us via a virtual whiteboard platform called MURAL. And I'm going to drop the link in the chat. So MURAL will open in your browser. It may be very small and you can use your mouse to scroll in via the mouse scroll button, or there's a plus sign in the bottom right-hand corner of your screen. There's a question at the top and we'll invite you to double click to type in a sticky note to respond to that question. If you see something else that somebody wrote that you agree with, you can copy and paste a thumbs up to like that. If you have trouble accessing MURAL today, that is okay. We should have some time at the end where you can answer in the chat. Speaking of chat, we invite you to ask questions of our panelists via the chat window. We also invite you to join us today with emojis, to join us on video, and to join us on Twitter. And of course, we're going to adhere to Siren's agreements for a safe and brave meeting. So one that resonates with me is to practice active, judgment-free, and empathetic listening, which for me means to remain curious and open to hearing different perspectives. And with that, I'm going to turn it over to Christine to start our panel.
Thanks, Jennifer. So like Jennifer said, my name is Dr. Christine Ogbue. I'm currently a senior advisor for the States and Population Health Group at the Center for Medicare and Medicaid Innovation. For those of you who are not familiar with the CMS Innovation Center, the purpose of the Innovation Center is to test innovative payment and service delivery models to reduce program expenditures while preserving or enhancing the quality of care furnished to Medicare and Medicaid beneficiaries. The Accountable Health Communities Model, or AHC, which is what you will hear reference to a lot through this presentation, AHC is a model test directly focused on investigating the impact of identifying and addressing the health-related social needs of high-risk patients on quality and cost. Patients are deemed high risk and therefore eligible for the AHC intervention if they screen positive for at least one health-related social need, or HRSN, and have had 2 or more emergency department visits in the last 12 months at the time of screening. AHC is a service delivery model, testing 2 approaches across 2 tracks. Participating clinical delivery sites use a CMS-developed screener for the 5 core domains of health-related social needs that are listed on the slide to universally screen every community dwelling benefit, Medicare and Medicaid, and duly eligible beneficiary who receives services at that clinical site. High-risk beneficiaries receive extra support from navigators to connect with community services and work towards resolving health-related social needs. This is the AHC intervention. Patients that are not deemed high risk receive standard care, while high-risk patients are assigned navigators that work towards resolving their health-related social needs. And so that describes the assistance track. The alignment track of the model layers on top of that patient level intervention and requires a cross-sectoral, data-driven alignment of community resources to close systemic gaps in the availability of resources to a community. For example, one requirement for alignment track participants is to establish and maintain a community advisory board that works towards ensuring community services are available and is responsive to the needs of beneficiaries. Next slide, please, Jennifer. This graphic shows the structure of the AHC model. CMMI directly funds the bridge organizations that are in the center of this graphic. And the bridge organizations are required to partner with clinical delivery sites, or overarching clinical delivery sites that make up the top of this graphic. They're required to partner with their state Medicaid agency, and they're required to partner with undergirding community service providers that can help address the 5 core domains for health-related social needs. The key innovations of the AHC model are systemic screening of all Medicare and Medicaid beneficiaries to identify unmet health-related social needs. The next innovation is the effectiveness of referrals and community service navigation on the total cost of care using a rigorous mixed method evaluation approach. And lastly, for alignment track participants, partner alignment at the community level and implementation of a community-wide quality improvement approach to address beneficiary needs. Next slide, please, Jennifer. So this map shows the location of AHC bridge organizations in April of this year. There were several types of bridge organizations that served different communities. Our bridge organizations serve rural and urban communities and range from a health department to community-based organizations to large health systems. Next slide, please, Jennifer. Now let's look at a model timeline to orient you all to where we are in the life of the model. AHC is a 5-year model that began in May of 2017. While model implementation was scheduled to end in May of this year, some bridge organizations continue to implement AHC with a no-cost extension. This brings me to the evaluation reports at the last column of this table and the timeline for those reports. The evaluation reports help us flesh out the lessons learned from our model test. Currently, 1 of the 4 planned evaluation reports are available to the public. The second report is scheduled for public release sometime next year. Next slide, Jennifer. The purpose of the evaluation report is to help us determine the model impacts. Our evaluation team used a mixed methods approach to analyzing AHC data. If you would like to read AHC's first evaluation report, you can click on the hyperlink available at the bottom of this slide, or you can also Google CMMI AHC evaluation report, and you can pull up the entire report and take a closer look if you have any questions or you want to know more. Now let's drill down to what the first evaluation report indicated about racial ethnic minorities. First, we found that beneficiaries that were eligible for navigation were more likely to be low income. They were more likely to be racial ethnic minorities. And among Medicare beneficiaries, they were more likely to be disabled. Next, the beneficiaries served by the model were stratified by race and ethnicity and Medicare and Medicaid status. Compared to the first table on this slide, in the next 2 tables, among Medicare and Medicaid only navigation eligible beneficiaries, racial ethnic minorities were overrepresented. This confirmed that AHC implementation data could tell us more about disparities, and not just traditional health outcome disparities, but disparities regarding screening, navigation, and the resolution of health-related social needs. Next, you'll hear from an AHC organization about their work using implementation data to illuminate disparities and inform health equity strategies. Dan, the floor is yours.
Thank you, Christine. So I'm Dan Behrens. I'm manager of population health at Allina Health, which is a large healthcare system based out of the Twin Cities of Minneapolis and St. Paul in Minnesota, also serving Western Wisconsin. Here we go, the about us. So you see we have 12 hospitals, over 90 clinics, and many other services from birth to death, but primarily supporting about a 10 to 12 county metro area around the Twin Cities. Next slide. So as a bridge organization participating in the AHC model, we pride ourselves in our ability to scale this up across almost all of our sites and care delivery sites. On the left-hand side, between June, when we started screening for this model, and January of this year, when we finished, we had almost 1 million patients that were eligible for screening, and folks were offered this screening every 6 months when they came into the clinic or one of our few hospitals participating in the model. You can see we offered the screening to just under 600,000 patients during that time frame, with almost 267,000 of those screenings being completed.
Can't we just take it out if it looks good? Yeah.
All right, sorry for the background noise there. And then screenings with 1+ need, you can see we had a need rate of about 23%, with 28% of those completing the screening identifying a need. Next slide. So we did map out all of our needs data across our service area. And so this is by zip code. And you'll see the darker blue indicates higher rates of need. The lighter blue indicates lower rates of need. The message here is that unmet needs affect all of our service area. It's not just a urban problem. It's not just a rural problem, but you're seeing some of our highest rates of need spread out across suburban, urban, and rural areas that we're supporting. Specifically, I'll highlight Western Wisconsin. We have 2 zip codes that are some of our more rural areas, as well as our far north and far northwest portions, where we see need rates just as high as they are in the middle of Minneapolis and St. Paul. Next slide. And drilling down with the needs data by specific populations, we really were curious as we're filling out our health resource equity statement, one of the many fun reports I got to send to Christine over the course of the model. But this one actually highlighted some really interesting information for Allina to focus in on at a more in more depth and at a deeper level. One being the difference in needs rates, as highlighted by Christine already, between our white and non-white patients. And so at Allina, we have the simplest breakdown of the 2 populations by comparison and equity group. Comparison group for Allina is anyone who is white, non-Hispanic, US born, and English as a primary language. The equity population is anyone that falls outside of that group. So you can see in the dark blue, really breaking that down by some of our larger subpopulations within that equity group, we had need rates that were almost at 50% of those screened for our American Indian population. We also saw almost 40% need rates among African American, Hispanic, and Hmong populations that we support. And then by payer, you can see dual eligible had the highest need rates, with Medicaid just following close behind. Next slide. So as we were filling that health resource equity statement out annually, we'd typically be looking at how we're doing with staff training, community engagement, to support communities, as well as culturally responsive care. As we got further along in the model, we did start to notice a particularly concerning trend in that we were actually offering the screening at a lower rate to those folks that are in the equity population than in the comparison population. That's especially concerning because of the need rates we just saw in the last slide. But really the largest disparity in that offer rate we were seeing in our clinical settings was actually at the peak of the beginning stages of the pandemic. So this slide on the top, the graph is going to show you in 2020, the difference there, the delta between our comparison and equity populations in screening. And hard to see and without getting the ruler out, but I would say we were at over 10% for a good third to almost a half of the year in 2020. And we started to see that disparity shrink a little bit, which I'll speak to in the next slide, come August. Sorry, I'll have to go back one more time. You can see by population, we saw that disparity at almost 20% for our Hispanic populations in April and May of 2020. All right. So our approach to reducing that disparity in screening offer rates was really to start by pulling together a team of stakeholders across the organization, from our equity, from our clinical care delivery sites, from our population health team, from our community benefit team, to really start digging in and finding out ways that we could operationalize solutions here. And I think the simplest but most effective strategy that we had was actually being very transparent with our data. So we had the ability to drill down by site and by population to really highlight where those disparities were the greatest. And oftentimes that data, is non-personal. It's very much just, this is what it is. And being able to share that with leadership across the organization, have them cascade that down to the site staff that were doing the work and offering those screenings, we saw the numbers increase. That data was actually shared for the first time in August of 2020. And you could see in the slides how much the disparity shrunk then in that last part of 2020, in large part because when you see data like that for your site in particular, that really does start to highlight where we can do better as a care organization. Also really trying to figure out what that root cause was. We were interviewing with that equity team, we were interviewing staff at the sites where we saw the largest populations of equity, subpopulation patients, as well as those sites that were struggling the most with offering screening to non-white patients. And we were able to break down some of those personal and organizational barriers, both real and perceived, that they were experiencing. One thing we heard, and goes along with the timeline that you saw, the largest disparities, is that when staff were crunched the most during the beginning stages of COVID, when there was the most change, they were least likely to provide that screening if there were concerns about language or about cultural understanding of the why. Oftentimes it takes longer, obviously working with a translator or providing that screening in different language to talk through the why and the what, but we highlighted that that was a big pain point early on in 2020, and that it's not an excuse not to offer that screening. And so those interviews were really insightful and helped to provide us with a more clear path as to how we could improve across the entire organization. So continuing to share that data, we actually highlighted that to the system scorecard. So that was something that our executive leadership team was looking at monthly for the last year and a half of the model. And we saw that improvement in the later part of 2020 sustained in 2021 as well. We also worked to make sure we had scripting developed to work with interpreters on how to introduce this screening to those patients that were non-English speaking. Also worked with one of our community partners, Health Finders Collaborative, on cultural humility videos that provide really insightful information on some of the populations that our staff may be less familiar with. Next slide. And so I guess just how does that work when you're actually trying to break it down into some more focused engagement with our community partners? And as after I'm done with this slide, I'll hand it over to our OpenPath resources partners. But a couple of examples that we've looked at over the past few years, one being looking at decreasing preventable readmissions in our Native American population, and the second being increasing colorectal cancer screening rates in our African American population. Both of those really operational initiatives across the entire organization are focused on shared tactics of health-related social needs screening and support, as well as community-led leader collaboration. And in the gray there, you'll see some of the tactics on what has worked or what we're trying to focus on for those improvement efforts, improving care transitions, really being more collaborative with the interventions we're providing, ensuring that we do have community health workers available to support those communities directly in the clinical sites to help connect and to work towards some of our clinical quality initiatives, as well as our equity goals. So with that, I will hand it over to Sharif from OpenPath Resources to highlight how some of this collaboration has worked for OpenPath in our communities.
Thank you, Dan, and thank you all of you. My name is Sharif Mohamed, Imam, one of the local mosques in Minneapolis, called a Dar al-Hijra Islamic Civic Center, which is the first mosque led by the Somali community when we came to the state of Minnesota since 1998. Also co-founder with Open Path Resources, right now kind of part of this presentation. My role as an Imam or the faith leader for this, it is use the faith Islam as an asset for the public health, and that's what I think enter for this relationship. And the relationship itself between a large healthcare system like Allina Hospital and community-based organization, sometimes it's not honestly easy, but I think this one, because the attention and the interest from Allina was working very well. As you see here, the community leader for last 20 years addressing significant disparities in social discrimination of the health, which what I mean by that is to use the faith as an asset and also kind of work with the healthcare system, whether it be hospitals or clinics, or even sometimes for a MDH, Minnesota Department of Health. As an example for that, when 2017 measles outbreak came to the state of Minnesota, a lot of the cases was related for the Somali American kids. And myself, my organization will reach out to the MDH, and we said, you are not able to solve this issue by yourself, by alone. I think you need to partner with the community, with the faith leaders, with the centers. Then we came up with a strategy and the MURAL, which is the faith leader and the public health. Both kind of go together and present the topic of the vaccine and how the vaccine is very important. And the reason we're doing that, when you shape the belief system, it's easy for, I think, to change the behavior. That's why kind of we're coming from the faith perspective and use that one. Also, as I said here, faith is a central guide and also resources to address the health equity and equality for care. Here, I think I want to kind of focus for this bullet, the structural relationship between mainstream systems and the health care. As an example, what we mean by that is, I think in general, the health care system kind of one-way talk, which means we are expert, we know what you need, we know what's wrong with you. Therefore, this is information. For our model is, I think, the community has their own structure. The community has their own way also. Therefore, partner with the community, and the kind of relationship has to be built, the trusted relationship, the kind of understanding relationship, and even why we're doing this one, why the healthcare kind of do this topic, why we focused for this one, why all of that. I think it creates that mechanism of understanding and build the trust was very important, and also succeed for that. Next, please. And as you see here is the spiritual care was a kind of for us. And the reason I think in general is, especially as Dan mentioned, the COVID-19 and also kind of how that affects all of us, but also the people of color and the immigrant specifically was very high. And when the person in the hospital, the stress and the fear is very high too. For us, I think East African immigrant Muslim community, Islamophobia is very high, and we know that. And the healthcare is not immune from that too. We are part of a system in general. Therefore, I think for us was go through the spiritual care and kind of talk to the spiritual department for a lot of different hospitals, but specifically was Allina for that, and create, if possible, for entering that. And we did that one, and with the help of the Allina system for that. And I think that was a kind of a plus for the community and also for the healthcare too. As you see here, we develop a training kind of we call culturally responsive care. And I think that training and that model, as we see the next slide, was well attended and also was well suited for both, I think, the community perspective and also for the healthcare perspective too. And you see here this kind of slide. When we some of the topics, maybe before we move this one, some of the topics we talk or that training was introduction to the Muslim faith and Somali Muslim culture in Minnesota. Some of the was also end of life conversation, which is usually very tough and very sensitive very sensitive. Also, the mental health, chemical dependency, addiction, which is in general mental health, I think is taboo for a lot of cultures, but East African immigrant is very taboo. Therefore, how to enter that one, how to open the conversation, how to start the conversation, all of those ones was part of the training we did. And as you see, the people who attended that one was part of the whole system, means whole Allina system, whether it be doctors and nurses, surgeons, social workers, coordinators, that kind of people attended for those trainings. And I think it was kind of show the importance and the interest for that. Next slide, please. Good. And as you see here also, what was most helpful for those, I think, training, when we asked the people what was very important for them, kind of all of those areas. But I want to highlight, I think, a few of them, which is, for example, kind of a practical application. Sometimes we kind of give them a practical application, how to talk a East African Muslim patient when you receive them, when they come to your office, how to talk to them, how to approach. For example, even if you say the vaccine is very important, taking the vaccine is saving their life. Sometimes if you say that one, and maybe the patient is saying, no, the vaccine maybe has a product of gelatin, pork, therefore I don't want to take. The conversation usually is stop that. For them, we give them a little bit, no, deep in that one, say how, why that. I think according to the Islamic kind of tradition in general, saving the life is very important. That kind of give them a practical application. Another one was the most of the presentation was a style of conversational. It's not just for us talking, but was a lot of conversational input from an imam like myself or some other people, I think. Another was kind of framing the faith and culture as an asset of care, which is, I think, is very important in this time for East African immigrant Muslim community. The faith and the culture, and I think in general, they care, they have their structure, they have therefore working with them for their structure, I think was very important. And some of the handout ongoing. And next step, please. Also, least helpful, as you see here, the virtual format, which in general, last 2 years, it is what we are doing and what we are doing right now. That kind of was one of them, which is for me, honestly, I don't like it a lot, but we have to do because we are in this time. Another one, was as you see here, the balance of the content with the time, large amount of content in a short amount of time, sometimes plus and minus both was another one, I think. Another one, which is, I think, for even coming from us, it's all from a male perspective, which is we knew that one and we kind of tried to work on, but we didn't succeed. And I think in the future we have to work on that one. But as you see, that kind of was the feedback we get from the participants is how to improve, and they also give us some kind of what's the next steps for. But I think for the time of the presentation, I want to stop right now and thank you so much.
Thank you so much. We appreciate the presentations today. We've had a lot of questions in the chat and Dan has been diligently responding to many of them, but I'll read a couple out loud now before we go to our audience participation. So one, either for Dan or Sharif that hasn't been answered yet. How did the relationship between Open Path Resources and Allina Health get started?
Dan, do you want to address or for me to yourself?
I'll have you go for it. And then I think we do have Vivian on the line too.
All right,
she may be able to chime in if we can turn her mic on. Wonderful. As well.
I think how the start was in general, I think when COVID, as I mentioned, was kind of very high in the kind of in the country and the world, and also several cases taking place in the Allina system. They need some kind of help for that. And also that time was more of George Floyd, and specific cases have been inside of the Allina hospitals, and they need a little bit expertise for that, how to serve better for East African immigrant Muslim community. And for us, as I said, a little bit kind of through the spiritual department, we communicate for their spiritual department here for that time and kind of talk about, I think, what we can offer for them. And even before we kind of formalize the specific partnership, we guide them and give them some kind of, say, feedback, or some of the cases was a little bit kind of what sometimes healthcare call for a debriefing, how to kind of maybe do those cases. If something happened and maybe want to kind of say it's not a right way, how to kind of not doing the same again, that kind of, then starting from that, I think, they said, I think we need your expertise, we need what you can offer, we need what we can do together. Then we start from that. Then you want to have something, or is Vivian there? I think you can both.
I'm here. I'm happy to chime in. Thank you.
All right.
Yeah, so you definitely highlighted sort of how the partnership started. We valued the partnership and your ability to sort of debrief with some of our care teams. We also were trying to figure out we knew that additional staff needed access to just the knowledge and expertise that Imam Sharif and his team have. And so we wanted to extend access to just, some crucial conversations in helping to understand community perspectives from the voice of community, and continue to strengthen that relationship and help folks see, or give folks a safe space to ask questions and engage in dialogue. Thanks.
Okay, and Dan again has been diligently responding, but Dan, I'll ask you to respond or expand a little bit. One of the questions at the beginning was if you could speak to tactics to improving response rates, in particular, or how to engage clinic staff. So could you share a little bit more about either of those, either improving response rates or engaging clinic staff?
Yeah, well, I think they go hand in hand, as we had our clinical staff, and I've, in one of my responses, mentioned primarily our screenings were driven by in-person staff providing that screening tool during the check-in process and during rooming as well. And so oftentimes in terms of performance improvement and quality improvement around providing the screening, it was leading with that data. We had process measures that were on our system scorecard for offering the screening as well as completion of the screening. And we really took time to highlight those sites that were having success, bringing kind of a lunch and learn format together where all of our 70 clinical delivery sites could hear from each other on what's working, what's not, what areas have been challenging. But I would say, that was often sharing of scripting, just getting more and more comfortable having the conversation. I know in 2018, bringing a screening about social need forward in the clinical setting felt a lot different than it does today at our organization. And so people with that repetition, with continued success and positive feedback that they're receiving from patients that are coming in and thanking them for asking these questions, I think really does build up confidence on how to offer that screening in a way that gets the highest rates of response. I would say also that those results were shared on a weekly basis with leaders across the organization at each site. And there's quite a bit of friendly competition, I would say, that was observed, where we had like a March Madness contest of like a bracket where clinics were facing off against each other to see who could offer the most screenings, percentage-wise based on their populations. But I think just in general, people see red and they want to turn that to green on their scorecards. And so just that highlighting out of where there are opportunities, really celebrating the success stories, and then partnering side by side with the sites that were having more trouble with it.
Thanks for expanding on that, Dan. We have time for about one more question. So if anyone has something they haven't asked yet, feel free to put it in the chat or come off mute to ask your question.
I can ask a question. I'm curious, so it sounds like the partnership with Imam Mohamed's organization seemed to focus a lot on COVID. I'm wondering, how has that been extended to work around social risk screening? And if so, kind of how has that informed that work?
Yeah, so at a high level, we've provided referrals through the technology we're using at post-screening to over 1,000 community organizations that are working with Allina patients. And I would say that we are working closely with our equity team, with Vivian and her team, as well as our community benefit team, to continue to see where we have partnership opportunities to more strategically partner on food insecurity, or on housing instability, or on social isolation, volunteerism opportunities. So we're doing a lot, I would say, across the board to ensure that we're bringing in community into that conversation to inform care. And I think, with Open Path resources, we're sending folks their way, whether patients know it or not. I think we're able to share the resource itself, and we're able to connect. And I think obviously continuing the conversation of how we can collaborate further and how we can bring in some of the great work that's happening in the community, and highlighting that for our clinical teams who are maybe caring for the patients in the clinic or in the hospital. Anything you'd want to add to that, Sharif?
Thank you. I think for years, we are kind of very focused, very heavily last 2 years for the COVID, but also we do a lot of other public health arena too. For example, we are right now even creating several videos talking about specifically encouraging the community, for some portion of the community, for the cancer screening. And the people who kind of do that one, a person like them, that kind of talking about, and also sometimes the style of conversation, a husband and wife, who each one of them encourage the other one, hey, did you get your breast cancer screening? Did you get that screening, that kind of stuff? And then maybe the husband or wife say, no, I'm okay, I don't need that, why I'm doing that? Then the other one say, I think that's very important when you kind of reach certain age. This is very important, even if you are healthy, it is very important for you. And the benefit is, if they detected early on for kind of the stage 1, or even before that for the cancer could be cured, that kind of stuff. If that's the case, then I want to go right now. And we are creating some kind of messaging for that. Also, we are kind of very involved in, especially kind of last year, I think a few months specifically, for the mental health, which is also increasing a lot. And we are not only for the COVID, we are different elements of the public health in general. And what we believe, I think, and many of you also know that and believe, is the hospital, or between maybe the hospital walls, only 20% of the health taking place between walls of the hospital. The 80% is outside. Therefore, how we can work with healthcare system in order for the community have some kind of building their capacity and able to support the community and family patients when they are outside of the hospital. We have been working with them right now, and Vivian was a very champion for that. And I think we need to work more on that. But yes, we are focusing last few years on the COVID, but we are not only for working on the COVID side.
Anything you'd add to that, Vivian? I know I see you're on the video now too.
I think maybe even just high level, when we think of equity, there's lots of factors and lots of things we need to do to address equity, right, at a high level. And so screening for social needs is one angle, but also the cultural perspective is critical. And I think all those pieces are just as important. And so as we are working with community, yes, to connect folks to community resources, but also how do we bring the perspective, the cultural perspective into our facilities and our discussions to ensure that social needs, cultural perspectives are all informing how we deliver care. So that's all I wanted to add.
And I think just one other thing that I would add to Sharif's comments is with the mental health in particular, I think we're not necessarily screening for mental health is a part of our social needs screening. We have PHQ-9, we have GAD-7 to look at some of those things. But so often those needs come up when you start unpacking how we can help resolve other financial concerns or social isolation concerns. And so I think that's a huge part of what this ongoing navigation need is in our communities, where we can continue to have that depth of conversation to get at, okay, we can help with food. You also have some severe mental health crises right now that we want to be able to help with, and being able to continue that conversation and then bring it back to the healthcare system too, to say, okay, we've got mental health professionals, we've got access that we can support. And so continuing to ensure that that's a two-way communication path, and that we can really best support those folks coming in for care.
We want to say thank you for such great questions. It really shows the depth of the expertise in this room, and that's why we want to spend the last couple of minutes hearing from all of you. So if you have questions for our presenters, you can continue to ask them in the chat, but we also want to turn to you. So I'm going to turn us back to the mural board. I'll put the link in the chat again. Reminder, it opens in your browser and you can zoom in with your mouse or in the bottom to zoom in. If you're having trouble accessing the mural, that's okay. I've typed the question into the chat and you can respond to the question in the chat. So I'm now going to share my screen with the mural board so you can all see it. So in today's presentation, we heard from our presenters about social needs screening and navigation, and those processes require working with patients, health service providers, community service providers, health systems, and policymakers. And so a question for the room today is, from the presentations or from your own perspectives, what are some lessons learned for engaging each of these groups to drive equitable change? So I'll give you all a few moments to double click into a sticky note to type your responses. Again, if you're having trouble accessing Mural, you can answer the question in the chat. Okay, so far I'm seeing a lot of typing happening in the patients bucket. Seeing some lessons learned around scripting. So scripting language that doesn't make patients feel targeted. Working with trusted partners. And as we see a thumbs up here, so if you see something you agree with, you can drag a thumbs up to that sticky note. We have patients and families must be able from the start, or must be at the table from the start of any project. I'm also seeing several stickies being populated in the health service providers and the community service providers. Does anyone who's typed a sticky in one of those buckets want to come off mute and share more about a lesson for engaging and working with health service providers or community service providers? Okay, I'll go ahead and read a couple more. So in health service providers, connecting the screening to the organization's mission, disaggregating data by race, ethnicity, and language. In community service providers, seeing similar to the patients, community service providers should be at the table from the start. And it's important to take an environmental scan to understand what is available. We're getting a couple now in health systems. So for health systems, some of the lessons learned we've heard are transparent monitoring and data, embed in key performance dashboards, and the importance of getting support from the administration on top. So before we close this exercise, Dan, Christine, or Sharif, are there any lessons that you're seeing that really stand out to you?
Just say I'm glad that that aligns with what we talked about today. I think that was the goal. So I'm hopeful that you guys have learned something and that you can feel free to reach out to any of us. And I'm sure we'll be able to continue the conversation from today as well.
Well, with the last minute left, we want to thank everybody for attending our session today, and thank you for sharing your wisdom with all of us as well. As we've heard before, Siren will make the slides available at a later date, and we'll also send along a copy of this mural board so you can all see the lessons learned. Again, thank you so much for attending our session, and we look forward to seeing you at other sessions throughout the conference today.
Thank you so much.
Thank you all.
Thank you on behalf of Siren and the organizers. Thank you to our presenters. A nice round of applause.